Dr. Neha.
Yes, sir. Thank you everybody for attending today's session. Today we have with us two wonderful mentors, Professor Rajgopal Shenoy sir from KMC Manipal, author of the famous textbook Manipal Manual of Surgery, and Professor Srinivasan sir from Coimbatore Government Medical College. Thank you so much for taking your time and guiding us today. I'll be presenting a case. I'm Neha. I'll be presenting a case of swelling on the neck today. So shall I start?
Please.
Yeah, please go ahead.
60-year-old lady, Mrs. X, who hails from Malleshwaram, Bangalore, who is studied up till 8th standard and is a homemaker by occupation, presented with a chief complaint. Go to the next slide. No? Presented with a chief complaint of swelling in front of her neck since 10 years. Patient was apparently well 10 years back when her relatives noticed a swelling in front of her neck about 2 into 2 centimeters in size, insidious in onset, gradually progressing to the present size of around 12 into 10 centimeter. There is no history of rapid increase in size of swelling and no history of pain over the swelling. Patient doesn't complain of any history of palpitation, loss of sleep, excitability, irritability, appetite increase, diarrhea, heat intolerance, hyperactivity, hair loss, and unintentional loss of weight. There's no history of increased fatigability, weight gain, increased sleep, constipation, cold intolerance, and mood changes. There's no history of difficulty in breathing, difficulty in swallowing, and hoarseness of voice. There are no other swellings. There's no dyspnea, no cough, no jaundice, and no history of bone pain. Past history. There's no history of previous surgeries, no history of long-term drug intake, no history of any radiation. She's not a known case of diabetes, hypertension, TB, asthma, epilepsy, or any other chronic conditions. Treatment history. She's not on any medication. No history of use of thyroid-related medications, and she has no allergy to any substances, no known allergy. Personal history, the patient's appetite is normal, diet is predominantly non-vegetarian food. She consumed iodized salt and does not consume much goitogenic food. Sleep is adequate. Bowel habits is regular, bladder is regular, and there are no addictions. Menstrual history, age of menarche 12 years. She had regular cycles of around 28 plus or minus 2 days, and she attained menopause at 50. In family history, no history of thyroid-related diseases in the family, no family history of cancers, no history of thyroid swellings in the neighborhood. Summary, a 60-year-old lady postmenopausal came with a complaint of painless progressive swelling in front of the neck since 10 years, with no features suggestive of compression of adjacent structures, hypo or hypothyroidism, and no features suggestive of metastasis.
You go to the first slide.
Yes.
You will start. Before going into the history, let me ask you, can I ask sir, please?
Sir, please, you first ask, then after that I will ask, no problem.
Tell me the basics of thyroid. Why it is called thyroid? What is the meaning of thyroid? Name.
It's a butterfly-shaped gland. So I don't know what is the meaning of thyroid.
No. The meaning actually, thyroid means red Indian shield.
Shield.
It's like a shield protecting. Okay. Now tell me, there are two lobes you said. Connecting the two lobes is the
isthmus.
Right. What does that correspond to?
The tracheal rings 1, 2, and 3.
1, 2, and 3. Please modify.
Little bit modify.
Come down.
2, 3, and 4.
Yes.
Right. Now, what is the functioning unit of a thyroid?
So the thyroid has lobules which contain follicles. The follicles have the thyroid, the secreting cells, and in the center is the colloid.
Now, briefly tell me the arterial supply of the thyroid.
The thyroid is supplied by two main arteries. One is superior thyroid artery, which is a branch of external carotid artery. It supplies from the upper pole. And then there's the inferior thyroid artery, which is a branch of the thyrocervical trunk. And yes, sir. And sometimes there's also a thyroidal ima artery, which is an additional supply in some cases.
Branches from the tracheal and esophageal branches also supply. Okay. Right. The venous drainage.
So venous drainage is the superior thyroid vein, the middle thyroid vein, and the inferior thyroid vein. The superior thyroid vein drains into the internal jugular vein. The middle thyroid vein also drains into the internal jugular vein. It's short and it's the shortest one. And the inferior thyroid veins, the innominate vein.
Tell me two important nerves which are associated with thyroid.
So the external laryngeal nerve and recurrent laryngeal nerve are closely associated with the thyroid. The external laryngeal nerve is a branch of the superior laryngeal nerve, and yes, and the recurrent laryngeal nerve is present at the tracheoesophageal groove. And
okay, leave it. Now, why does that thyroid move up with deglutition?
So the thyroid is enclosed in the pretracheal fascia, and the pretracheal fascia has a condensation called Berry's ligament, which is connected to the cricoid. Since the trachea and the thyroid and cricoid cartilage move up with deglutition, along with that, even the thyroid gland, because it's fixed, it's attached to the cricoid, it moves up too.
How is the cricoid cartilage pulled up?
Because the constrictor muscle, like the inferior constrictor muscle.
Right. Okay. Right. You are answering. Sir, please take over, sir.
Yeah. So, Dr. Neha, you answered well. So, good theory preparation. One or two things you should know. We need to definitely not put the identification of the patient, that is a name, but you can always tell this is a checklist for you: name, age, address, education, occupation. You know how you can present this? 60-year-old lady coming from Malleshwaram, Bangalore, 8th standard by whatever the educational status, homemaker by occupation, presented to the hospital with a swelling in front of the neck of 10 years duration.
Yes, sir.
Clear?
Yes,
so
sir.
You never say Mrs. X and Mr. X, etc. Is it clear?
Yes, sir.
It's a simple. These are all the checklists for you. Even in the examination, when you are asked to describe the swelling, you don't have to tell size 6 centimeter, surface smooth, not like that. Surface is smooth, borders are round. It make a continuous sentence and present the case. I hope it's clear. So, 60-year-old lady coming from Malleshwaram, Bangalore, 8th standard by education, homemaker by occupation, presented to the hospital with following complaint. Right, next slide. Yeah, so this is how it is. Complaint of swelling in front of the neck, 10 years duration. So whenever you have a patient who comes with a swelling of 10 years duration, what is the first thing that you come to your mind? First thing, forget about thyroid and etc. in general.
So the first thing is, why hasn't this patient come before, since the swelling has been present since 10 years?
What do you think the reason in Indian scenario?
So since she's a woman and maybe it was ignored and she didn't have any pain or any such.
I agree with you, but what answer I wanted always remember for any swelling for that matter is, sir, most probably we are dealing with benign swelling. That is the first thing I want to understand. Is it clear?
Yes.
Very fact that she has been living with this swelling for 10 years. That means most probably, see, nobody can tell with 100% surety. So when I ask you, what do you think by first inference of 10 years, your answer should be, sir, most probably benign. Then the second question we ask you is, why she has come after 10 years? For that, you just now told me many reasons, like a women. Why women will come little late compared to men, according to you?
So
Yes.
maybe their complaints were not taken seriously in the house.
So that is why, Srinivasan sir, we are seeing more girls are taking up surgery now, so
Yes,
that
sir. Yes, sir.
they are going to educate. That is 100% true, Neha. That is the women have to do a lot of responsibility in the house. You know, they have to look after children, husband, in-laws, so many issues. Let us not divert that. Yes, generally, they come late. Maybe a financial considerations, maybe a literacy, or maybe somebody has not taken her to the hospital. Whatever be the reason, is it clear?
Yes, sir.
Right? So that may be the reason that she has come. She is a 60-year-old lady, and it has started at the age of 50.
Yes,
So
sir.
does it make a difference to you when it is 20-year-old lady coming at 30 years of age?
Yes, so the age is important in thyroid swellings. Like we can think of few etiologies. Like if they are young, it could be iodine deficiency. It could be a rare dysharmonogenesis. It could be it could be puberty or pregnancy related goiter. At an older age, the chances of at a younger age, the chances of papillary carcinoma is also high. At a middle age, the chances of colloidal goiter or a follicular carcinoma is higher. At very old age, there's a higher chance of anaplastic cancers.
Not truly very old age and all that thing what you mentioned. That is all right, more or less. What the answer I wanted was younger means they would have even worried about cosmetic. Is it clear to you?
Yes.
Cosmetic. Moment she is 50 plus in the house, you know, there is a usual saying in Kannada, "Nimge and madve aglikkidiya" anta, something like that. So she's already married lady. So that is the reason. One reason they are coming late to the hospital, right?
Yes.
Yes. Now, shall we go, sir, further?
Yes,
Yes.
sir.
Next slide.
Please, sir.
Yeah. Now I noticed that 2 into 2 centimeter. See, I accept it, but some examiners, you know, they are little correct diameter, etc. So what you can tell is, sir, she showed me. Can you see my hand now? Can
Yes,
you?
sir.
So you just tell her, sir, she told me like this. So I think it is 2 centimeter approximately. Small 2 centimeter insidious onset, and it has progressed to attain the present size. You can tell. Here to say 12 by 10 is becomes difficult. You understand? I
Yes,
know
sir.
this is a very large one. People will jump on if you tell orange, if you pineapple, or if you tell watermelon, etc. So you can tell cricket ball. Commonly people know. So it has become large enough for a patient to show me, sir. That's why I said I guessed probably it is 10 centimeter. That's all we can say.
Yes.
Approximate.
Yes, sir.
Why did you ask that rapid increase in the size of the swelling?
So a rapid increase could indicate that there was hemorrhage or that there's a new onset malignant transformation.
Just hold on. Two things are different. A rapid increase means it is over a period of say few days, maybe 10 days, 20 days, 30 days, 1 month. That is usually a malignant transformation.
Yes.
Whereas hemorrhage means it is sudden increase.
Yes, sir.
But typically patient says, I have been having this for a long period of time, and suddenly yesterday I had even difficulty in breathing. That is not a feature of malignancy. That is a hemorrhage in a nodule over the isthmus. Is it clear? What is the most common site of a nodule?
The junction between the one lobule and the isthmus.
So not lobule, lobe.
Lobe, sorry, lobe.
So obviously, when there is a sudden hemorrhage, it causes compression of the tracheal cartilages. So rapid increase suggests usually a malignant transformation. Sudden increase suggests tracheal compression. Is it clear? It
Yes, sir.
happens in a hemorrhage. In thyroid swellings, you should bring this history of pain last. Is it clear?
Yes, sir.
However big is the thyroid swelling, pain is not at all a feature of thyroid swellings. Is it clear?
Yes,
Because
sir.
once you start initially only, examiners will go on asking you about the different causes of pain, and then you get stuck there. And so let us come to the pain later. Will not bring the, because pain is the last symptom of thyroid diseases. Is it
Yes,
clear?
yes.
Whether it is MNG, even if it is carcinoma, thyrotoxicosis, all that list which you gave, no, adenoma, this, that, it's very uncommon or rare. Rare things are rare. So we'll discuss it later. Next slide, please. Yeah. Now, what next you should have told at this juncture? See, you have written everything. I agree with you. Now, Neha, your thoughts have to be in some methodical way. You know why I said this? Always first is the thyroid gland. Yes. Progress. Yes. Anytime it has regressed in size, small size, when somebody takes it, somebody has a disease for 10 years, she might have gone to some local doctor, general practitioner. Somebody would have given her even L-thyroxine tablet. With that, it would have even become little smaller in size. All this information you need to take. That is one. Now, once that is done, your fifth line should come immediately after the swelling. Notice your difficulty in breathing, difficulty in swallowing, and hoarseness of the voice. That should come first. Local compression issues. Both breathing and swallowing are due to local compression on the trachea and esophagus, right?
Yes.
What is that called as? 10 years of swelling, compressing on the trachea, and patient feels a bit of, difficulty in breathing. Why is that due to?
So it's because of the pressure effect of the enlarged gland.
See, that's what I said. If you say pressure effect, you will pass. But if you tell pressure atrophy and tracheomalacia, you will get more marks.
Yes.
That's all. See,
Yes,
answers you know, but in that limited time during the examination, quickly you should come out. Sir, compression of the tracheal cartilages can give rise to pressure atrophy. That's a softening of the tracheal cartilages, even though tracheomalacia manifests usually after thyroidectomy. Is it clear?
Yes, sir.
Is it clear? Once you remove that thyroid, no, the trachea loses the support and collapses. That usually happens. That is one. Any other reason for thyroid swellings to have difficulty in breathing other than the tracheal compression?
So if it's extending like retrosternal, it could cause difficulty in breathing. If there is hyperthyroidism, then that can cause cardiovascular side effects, which can cause dyspnea.
And cardiovascular side effects. Again, correct yourself and tell a good sentence, good word.
So hyperthyroidism can cause like congestive cardiac failure,
See that.
which can lead to dyspnea.
So you know the answer. So you need to spell out in the exam fast, so that when the question is asked, be specific. And what is that called as in a long-standing goiter like this, multinodular goiter or whatever, causing congestive cardiac failure? What is this? What is this thyrotoxicosis called as? Yes. Yes.
So I'm not sure what it's called.
The secondary thyrotoxicosis, also called as Plummer's disease.
Yes, sir.
You know what is primary thyrotoxicosis?
Yes, so it's because of Graves' disease. There's mostly CNS side effects in primary.
Yeah, we'll stop it. Primary is called as Graves' disease. Secondary is called as Plummer's disease. Also, it is secondary thyrotoxicosis, right? Yes. Cardiac involvement is more common, and later, if you don't treat it, then only they will go for a congestive cardiac failure. Similarly, in primary, if you don't treat it as a severe manifestation, you know what happens to the eyes. Even a blindness also can occur. Progressive exophthalmos. So these are the two extremes. Nowadays, we are not seeing much, but you should remember, a patient who has got a multinodular goiter, complains of difficulty in breathing, consider a tracheal compression possible. consider a retrosternal extension, yes. Consider also a secondary thyrotoxicosis, right? So what I'm trying to tell is breathing, swallowing, hoarseness should come top in the list.
Yes.
Why difficulty in swallowing?
So that's a more advanced stage of compression because because of compression of the esophagus.
Which structure is more anterior?
The trachea.
Trachea. So esophagus is posterior.
Yes.
It's a posterior lobes. Laterally compressing may cause esophageal compression. Esophagus is a muscular tube, so it doesn't collapse, but definitely some amount of discomfort or difficulty in swallowing. They may complain, not that they will never complain. So it is possible even in a patient who has got large swelling. And hoarseness is due to
Recurrent laryngeal nerve. When that is damaged, then there's hoarseness of voice.
again don't say damage. What is the word to be used?
Compression.
No.
So infiltration of the recurrent laryngeal nerve.
See, in all, I have assessed you now already by your presentation. You know the answer, but it will not come first time. Like congestive cardiac failure, you said side effects of cardiovascular system. Infiltration of recurrent laryngeal nerve. So every word is important here. Tracheomalacia or softening. You just have to even say softening of the tracheal cartilages. So this will come first. Once that is done, again see here, you have written history of palpitation, then you have written loss of sleep, excitability, then fatigue, weight gain, sleep, constipation, all that thing. If they are present, you tell, or you can say, write as one sentence here. So no history suggestive of toxicosis. It gives an examiner to ask you a question. And when the examiner asks you a question, you again tell it in a methodical way. For example, primary thyrotoxicosis, you start with the CNS symptoms. All that you have written know there. How will you know that patient is irritable? Has she told you that I am not irritable? You have written what do you mean by irritable? Irritable means restless. Basically, they are restless. Primary. I'm talking about primary. So what answers you need to know, ask questions is, first is CNS symptoms. Next comes the gastrointestinal symptoms, right? So in that order you take one by one. They can also have skeletal system. For example, myopathy, difficulty in getting up. And you have already clearly mentioned she is post-menopausal. So we'll not ask that question for her about menstrual irregularity in a young patient. If you follow one method, one order. So no history is suggestive of toxicosis. What is that history you asked? Sir, in the form of CNS, I asked this. In the form of menstrual, I asked this. In the form of this, I asked. Similarly, why did you ask that increased fatigability, weight gain?
To look for symptoms of hypothyroidism.
Very important. So, one, no history of toxicosis, no history suggestive of hypothyroidism. One sentence is enough. If give a chance to the examiner to ask questions. No other swellings. What is that you are looking for?
So, for example, in follicular carcinoma, many times we see like swellings like in the skull or in the sternum and other places, which are like pulsatile swellings. So I've just ruled out that there's no other swellings.
That is fine. What is the more common thyroid malignancy?
The most common is papillary carcinoma.
What is the method of presentation of papillary carcinoma thyroid?
So generally a solitary, they'll have a solitary nodule.
And with or without?
With or lymph without? Node metastasis.
So
that swelling is not told first.
So when we ask, what other swelling, first is other neck nodes.
Yes.
Yes, if patient is intelligent or if she's careful, you can always tell After that, see, don't go on telling at a once pulsatile, bony, secondaries in the scalp and sternum, etc. You
Yes,
just
sir.
tell bony swelling. It gives an examiner to ask you a question, which bones? See, you know the answer. So which bones? So you say flat bones like that. What is the nature? Pulsatile. So that means you have asked, you have drawn the examiner towards you by 5 questions, which you know the answer. Is it clear to you?
Yes, sir.
So for the benefit of all the undergraduates here, just remember FBS. FBS means follicular blood spread. It does not mean exclusive, but I just want you to understand commonly it is blood spread. Again, FBS is follicular bone spread. Bone. Again, FBS is flat bone spread. See, easy to remember. So that you will never forget, because other way is papillary spread by lymphatics, follicular spread by blood spread. So easy way to remember. And another thing I would like to tell you at this juncture, nice that you mentioned as swelling. Thyroid malignancies like follicular will not produce that backache and all that, bony pain and all. They all produce like this swelling. If you have a bone pains, there's more destruction, and it is a feature of female, means think of carcinoma of the breast. In CA breast, we ask a low backache. We don't ask bone swellings. We ask backache, lumbar area or thoracic area. So CA breast produces more backache, and follicular carcinoma produces more bony swellings. Srinivasan sir, please.
No, sir. She has told you have told everything. You said 10 years duration. 10 years duration, you say what type of toxicosis you can develop?
They can.
Can the patient be having primary thyrotoxicosis for 10 years?
So primary thyrotoxicosis will generally have like eye symptoms and signs, everything at once.
Patient is having 10 years swelling. If he develops swelling, if he develops toxic symptoms, what is the, it will be a secondary thyrotoxicosis?
It will be secondary, yes.
So you should mention that first, okay? Is
Yes.
there a difference between thyrotoxicosis and hyperthyroidism?
And
hyperthyroidism.
Yes.
Thyrotoxicosis, hyperthyroidism is a type of thyrotoxicosis. Thyrotoxicosis doesn't have to be because of the thyroid gland. It can even be like factitious intake of thyroxine. It can even be struma ovaria or some ectopic production of thyroid. Hyperthyroidism is specific to when the thyroid gland is producing more thyroxine.
Yeah, you're going to, as Sir said, you can just mention no history of any toxic symptoms or hypothyroid symptoms. If they ask you, you bring in. Or if they'll start asking you what is the reason for excitability, what is the reason for irritability. So if the patient has got any symptoms, you mention that one. That is enough.
Neha, just again, your last sentence, swelling is all right. Cough, jaundice, bony pain. Remember, each malignancy has certain different behavior. So thyroid malignancies, even they take 1 year, 2 year, metastasis in the bone, metastasis in the lymph nodes, they rarely, I have not seen producing jaundice. Is it clear?
Okay, yes, sir.
So there should not be any reason for you to ask that and write in the case sheet.
Okay.
So please do not mention jaundice, because the day you mention jaundice, immediate question is, why jaundice? What did you have in mind?
So I thought for cough dyspnea was for lung metastasis, like that jaundice I thought would be if there's liver metastasis.
No. Again, liver metastasis do not produce jaundice, for your information, because it is normal liver.
Yes.
Unless significant liver, 70 to 80% is damaged, you don't get jaundice, number one. And nodes at the porta hepatis and all. See, don't go to too much imagination. Like no history of jaundice. Somebody's asked no history of epilepsy, no history of coma, cerebral metastasis. So there's no end for it. Is it clear?
Yes, sir.
In thyroid swelling, very specific. neck swelling and bone swelling. Enough. If it is papillary carcinoma, it will indirectly tell lymph nodes. If it is a follicular, it will tell probably a hematogenous spread. Enough. Anaplastic is more of a hoarseness of the voice. And medullary is a different situation, sporadic cases, what we see. It can be associated with the endocrinal ME and syndromes. They are different. So let us not worry too much about that. I think we can go to the next slide. Yes. Why did you ask history of previous surgery?
So if there's if it's like a recurrent condition, in case she has had any thyroid surgery before.
That is all right, because if you have a exam, there may be a patient who has undergone total thyroidectomy, and one case is given to you with the neck nodes. That gives you a clue that old case can be papillary carcinoma thyroid. Is it clear? So no history of surgery in the past. Why did you ask a history of radiation? And what radiation? Why?
So radiation for like conditions like lymphoma will increase the risk. Radiation in this area increases the risk of papillary thyroid cancer. Yes, so that's why I asked if she had any history of radiation.
I agree with you that if at all a childhood lymphoma. So if this in this lady it is possible, because when I say childhood means this is about 50 years back for this lady, and now she is 60. So yes, lymphoma, one situation. But what you should understand today is more than lymphoma, there are many head and neck malignancy children can develop. More than lymphoma, not just lymphoma. Nasopharyngeal carcinomas, or maybe a non-Hodgkin's lymphoma, even anywhere. So child who have been treated with radiation, that is one. Any other source of radiation any other source of radiation? Accidental radiation?
So I think historically, like the Chernobyl accident.
Historically means effects may be still there. One, any other possible? Any other X-rays, CT of the head and neck. Today, CT of the head and neck is asked for many conditions, especially for children also. CT of the head and neck. You know, even though it is for 15 seconds or 20 seconds today, fast CT, they have got a significant radiation hazards.
Yes,
is it clear? So that's what you should need to know. So radiation given for lymphoma, radiation given for a childhood malignancies of the head and neck, multiple CT scans of the head and neck taken for different conditions. They are accidental source. These are the various source of radiation. What is that long-term drug intake?
So there are some goitrogenic drugs. So I like thiocyanate, then para-aminosalicylates, then antithyroid drugs.
What is this para-aminosalicylate?
So I'm not sure.
So again for all undergraduates, anything which you are not sure, please do not mention in the examination. PAS is, I have seen the drug, I have given the drug with my hand only in a Ballari Medical College when I was an intern, but it is no longer used anti-tuberculosis treatment. Okay, pass. It stopped almost, I think, 30, 40 years back. Para-aminosalicylic acid. So more than two things I would have been happy if you were to tell. What is that anti-hypertensive drug?
So amiodarone.
See, you know the answer. Does it contain iodine?
Yes, sir. Amiodarone. Yes, sir.
Amiodarone is the one, and another drug is lithium. Okay.
Yes.
Lithium. So at least one or two drugs you should know, rather than PAS. Okay, tuberculosis, asthma, epilepsy, chronic condition, we need to take it for the sake of management of the patient. Sir, any questions, Srinivasan, sir? You want to ask?
No, sir. She's doing well, very well.
Go ahead. Go ahead, Neha.
Yes, sir.
How do you ask for thyroid-related medication? Huh?
So I asked her if she had got to a doctor specifically for that, and if she was prescribed any medication for that, and if she's been taking anything, but she didn't have any history of that. So.
If she's taking, how do you know whether the patient is taking anti-thyroid drugs or thyroid supplements? Patients, now all patients are educated.
So the dosing, I think.
Not dosing. One more thing.
Thyroid supplements is taken once a day, I think so. And
early morning, empty stomach.
Yes, sir.
Single drug is thyroid supplement.
Yes, sir.
2 times, 2 drugs or 3 times is anti-thyroid. Okay, that is how you exit the history, not on any medication. The allergic history. Go to the next slide. You have to go for the clinical examination.
Again, here, goiter, don't say does not consume too much goitrogenic food and all. All that is a old story of the cabbage, etc. Okay.
Yes, sir.
So again, consumes iodized salt. Today, every salt is iodized, for your information. So diet, say normal diet or say non-vegetarian. Okay, you wanted to add that, doesn't matter. You can say. Don't have to really go on telling iodized salt, etc. Okay. Insomnia, also called a sleep disturbance, is predominantly a feature of which condition?
So insomnia happens in hypothyroidism, but a hyperthyroidism patient can also have sleep disturbance because of they'll be like.
You are telling, I think, wrong. What did you tell? Insomnia happens in?
Hyperthyroidism.
So insomnia is a very, very important feature of, again, to give you more marks, you should use the word primary thyrotoxicosis. Is it clear?
Yes, sir.
Insomnia is a very strong feature of a primary thyrotoxicosis. The metabolic activity is so much high sympathetic activity, tachycardia, palpitation. It doesn't keep the patient, is all the time anxious, awareness of the beat, some kind of a dehydration also. So he doesn't get the sleep. Is it clear?
Yes.
That's the reason. Whereas hypothyroid means they like sleeping. Okay, I think we can go to the next slide.
Go to the clinic. What is the importance of family history, ma?
So there's some family history in thyroid, there can be some genetic conditions like MEN syndrome, where there's an increased chance of medullary carcinoma, like in MEN 2A and 2B. And there can be some familial syndromes like Cowden syndrome, and where there are multiple, like Cowden syndrome. And there can be dysharmonogenesis, and yes, sir.
All that you told is true, but what you should have mentioned is always endemicity. Endemic. What do you mean by endemic goiter?
So sometimes in certain neighborhoods, there are many cases of goiter in that neighborhood.
You are from Karnataka state. You are from Karnataka state. Do you know 1 or 2 endemic goiter areas in our state?
Sir, Muddenhalli, I know only that one, sir.
Maybe I do not know much about that, but see the Sakleshpur, Kurg belt, yes. Those are the patients mostly, either they go to Mysore or Mangalore. So wherever the hilly areas, hilly area, and then there's a low-lying area. But again, the incidence is coming down now. So that is what is endemicity, either one neighborhood, what that you are written there, family members. So all that other things, what you mentioned is not common. Is it clear?
Yes.
Not common. Okay, go ahead with the next slide.
Okay, you can go to the clinical examination, sir.
Yeah, sir. At this juncture, if they ask you what is your diagnosis, what is that you tell at this stage? At this stage.
Goiter and euthyroid state without any metastatic symptoms.
I fully agree with you. When you have a no hypothyroidism and no hyperthyroidism, when there is no features suggestive of more than telling metastasis, malignancy, that is the better word rather than straight away. There's no word about malignancy. The most common of a 10 years duration, either it's a colloid goiter. You know, galagande, the correct word which is used. You know Kannada?
Yes, sir.
Galagande, that is the word which used to be used, large or multinodular goiter. That's all. Two things.
Yes.
That's all.
It's been more looking like a benign swelling.
Correct.
On the history wise.
Yes.
Yes, sir.
That
Go
is
ahead.
better. Okay.
Go ahead.
The patient consent was taken and examined under adequate lighting exposure in the presence of an attender. Physical examination. An elderly lady, conscious, well-oriented to time, place, and person, cooperative, moderately built and well-nourished, sitting comfortably on the bed at examination. There's no pallor, icterus, lymphadenopathy, pretrivial myxedema, and clubbing. Normal hair luster. There are no eye signs. Oral cavity is good hygiene. Upper limbs is warm. There's no tremors. Lower limb is normal. Skin is normal.
Just hold on, Neha, 1 minute. Whenever you are presenting, you also need to know why you are asking that, looking for this related to your case. Why you are looking for lymphadenopathy in this patient?
So lymph node enlargement happens in malignancy.
So is it an important feature of a thyroid examination also to look for lymph nodes?
Yes, sir.
So it is not required, or you should not mention that during your general physical examination. Is it clear?
Okay, sir.
Your answer should be, sir, I looked for pallor because we want to know she may be 6 grams, 7 grams. So we need to take her for surgery or something. Icterus has no relevance in this patient. Sir, I will mention the lymph nodes later. Is it clear?
Yes.
Similarly, for all the benefit of postgraduates or undergraduates, in a thyroid swelling, again, no eye signs. You can always mention if it is there, you mention, otherwise I will describe it later in a case of primary thyrotoxicosis. Is it clear?
Yes, sir.
Oral cavity is okay, upper limb warm, no tremors, that's all fine. But lymph nodes need a separate examination. Last but not the least, pretibial myxedema and clubbing. Why did you suddenly bring that word pretibial myxedema? Who asked you to examine that now? Is your patient toxic patient? No.
No.
So don't get into trouble. They will go on asking you about pretibial myxedema. Yes, mentioning no edema of the feet is fine at this juncture.
Yes, sir.
Edema can be due to nutritional. You only said no. Women means generally, I don't say they're neglected, but they come late to the hospital. So no edema of the feet is fine. She is not in congestive cardiac failure, or she is not nutritionally deprived of. But don't mention this pretibial myxedema at this juncture.
Yes.
Let again give a chance to the examiner ask you, in primary thyrotoxicosis, what do you look in the limb? What do you look in the limb in primary thyrotoxicosis? Your answer should be pretibial myxedema.
Yes.
Do you know how it looks like and what it is? Unilateral or bilateral? What is this pretibial myxedema? Pitting, non-pitting?
So I think
You think yes?
I'm not fully sure, sir.
Okay, this is exactly it happens. It's both symmetrical, bilateral, symmetrical, mucin-like deposition, which is non-pitting in nature. So, and also you don't look for that pitting just about the medial malleolus, etc. It's a pretibial. The shin is area, these are the area. Skin is looking like bit of a coarse, so that's what a thickened like a tissue. So that's what I am trying to say. Just say no edema. Other way of putting the same question, what other examination you do in hypothyroidism, if this question is asked? in the leg, in the limb? Do you have any idea? Ankle jerk, slow relaxation. Yes, somebody has put that glycosaminoglycans. Correct. That is the answer for a deposition of the tissue in the primary thyroid. Yeah, I think you go ahead for the thyroid straight away. Yes.
Pulse rate is 78 beats per minute, regular in rhythm. Blood pressure is 130 by 80 millimeters mercury. Respiration is 14 cycles per minute, and temperature is 98.8 degrees Fahrenheit. Examination of the neck, inspection, a single ovoid swelling, size 12 into 10 into 8 centimeters approximately, in the anterior neck in thyroid region, extending from the upper border of thyroid cartilage to sternal notch and lateral border under sternocleidomastoid. Surface looks nodular. The skin on the swelling appears normal. The swelling moves with deglutition and the lower border is seen. Palpation, there's no local rise of temperature. It is non-tender. The consistency is cystic to firm. The size is around 15. The size is 15 to 10 into 8 centimeters, extending from the upper border of thyroid cartilage superiorly to sternal notch inferiorly. Lateral extent not made out as swelling extends under the sternocleidomastoid. Carotid pulse palpable on both sides. Lower border of the swelling is felt. The surface is nodular, consistency is variable, firm over most areas and cystic over few areas. Multiple nodules palpated, largest being around 3 into 2 centimeters on the left side. Trachea is central. Auscultation, no bruit heard.
The plane of the swelling, ma'am. Plane of the swelling is important, is it not?
Sir, it's deep to the deep cervical.
You mentioned your left it. Kindly add it, okay?
Yes, sir.
Plane of the swelling is important.
Yes, sir. Auscultation, no bruit heard in the superior pole. Systemic.
Just stop for some time. Go to the first slide of the inspection. Okay, simple question. This is a very big goiter, like an elephant size. Nobody can miss. If there is a very small swelling, and how to make it prominent to do the good inspection? This is a very common problem. Commonly asked question. Yes.
So actually, yes, sir. So if they extend the neck, then because it's deep to the deep cervical fascia, so in the book it was given that it becomes more prominent, but I had a doubt. Shouldn't it become less prominent because?
Just hold on. Just hold on. I will give the answer. So when you ask the patient to stretch the neck like this, next time, if you happen to go to the ward, maybe by November, December, sometimes you see, it's the cervical lordosis that happens. Is it clear? You know, lordosis means what?
The natural curvature of the spine.
When that cervical lordosis happens, it pushes the thyroid gland anteriorly. Is it clear to you?
Yes, sir.
And your second question, you are telling that, what is that second you are telling? You had a doubt. What is the doubt you had?
So it got cleared, so that was the doubt. Because it's
no, you're saying you asked the doubt.
Something else you mentioned.
When you extend, it becomes prominent. But how when it's deep to deep cervical fascia, how does it become less prominent?
Always, whenever you do some test for the plane means subcutaneous or deep or wherever, one important word many of you forget is contraction should be against resistance. Is it against resistance? You want to check for sternomastoid, don't say just turn the neck like that. No, you always push it to the other side. Correct? So when you extend the neck, are you really doing any contraction here? You are just passive stretching. Is it clear? It is, you are not contracting at all against resistance. You are only extending the neck. By extending the neck, there is a cervical lordosis pushing the thyroid gland anteriorly, so it becomes more prominent. I hope it is clear.
Yes, sir.
Second important thing, ovoid you have written, and 12, 10, 8, whatever it is. Always make a habit to mention, firstly, there is a swelling in the region of thyroid is very good. Anterior neck is good. Whether you say anterior or front of the neck and anterior, that is also fine. Extension, you are told nicely, upper border of the thyroid cartilage to the sternal notch and laterally, that is also fine. But what is this diameter transversely and what is the diameter vertically? That has to be made clear.
Yes, sir.
When you say 12 by 10, I don't know. Are you referring to vertical 12 and horizontal 10? Is it like that?
No, sir, it's horizontally ovoid. 12 is the horizontal and 10 is vertical.
So horizontally extension, you mean to say horizontal, it is more than vertical.
Yes, sir.
So what do you think, why it is like that? Why it is not butterfly? If your statement is correct. Yes.
Sir, it's not butterfly shape because there are many different nodules and the shape of the gland has been lost.
What I can guess is, if it is 12 centimeter horizontally and vertically 8 means left lobe is enlarged and right side the entire lobe is not enlarged. That's the only way I can think. Can you show the picture once? Just
yes,
once.
Left side is more enlarged than the right side.
Show the front. Yeah, left is more compared to the right. That is why, sir, she is telling it's horizontally oval. She's including the portion of the right lobe and left. Anyway, so go ahead. When you ask the patient to swallow, I agree. In Indian scenario, we just ask them to swallow. But remember, she goes on swallowing her saliva. She has hardly any saliva at the end. By the time you come and ask her to swallow, make a habit to give a glass of water.
Yes.
The fellowship examinations and all, they may consider these are the points for your whatever results or good marks. So asking the patient to drink a glass of water and make a mention, swelling goes with the deglutition. Already initially, Srinivasan sir has asked you why it moves with the deglutition. Invariably, you people tell Barrett's ligament. According to me, it should come last. You understand? Your answer should be thyroid is very nicely enclosed with the pretracheal fascia. So with the attachment of the Barrett's ligament and also pharyngeal muscles, constrictor muscles, and even a digastric muscles, they all act in a whole larynx upwards to block the respiratory passage. So because of these reasons, thyroid moves with the deglutition. So my question to you is, when thyroid does not move with the deglutition?
So it may not move if it's very large or if it's infiltrated like the strap muscles, or if it's infiltrated like in a carcinoma, like anaplastic carcinoma. In these two conditions, it won't move. And if it's very large and like retrosternal also, you may not be able to appreciate it moving.
It moves, but it moves with limited mobility.
Yes.
So, your radial thyroiditis, anaplastic carcinoma, and another one is your recurrent one. It moves with deglutition, but there will be restricted movement.
Yes.
Yeah, that is the word.
Don't tell infiltration to strap muscles and all. They are all complex. The best is to say infiltration in especially in malignancies to the prevertebral fascia. Yes. Is it clear? If there's a nodule in the lobes, the immediate posterior structure is prevertebral fascia.
Yes.
Once it infiltrates the prevertebral fascia, it doesn't move the deglutition. That is the reason why most of the anaplastic becomes inoperable. It's not just the question of recurrent laryngeal nerve. You can sacrifice it in malignancy. If it is infiltrating, of course, I use the word infiltrating, but prevertebral fascia. So you cannot move it in such situations. It doesn't move with the deglutition. Okay, go to the next. Surface nodular. Skin over the swelling, you have written normal. Yes, possible, but sometimes see carefully. large goiters, skin may be stretched, skin may be shiny, or even thin veins you may be able to see over the large thyroid swelling. No local rise of temperature and non-tender. Initially, when that history of pain, I wanted to ask that question to you, that why you ask a history of pain in thyroid swellings. Your answer should be to rule out thyroiditis.
Yes.
Is it clear? Thyroiditis, whether it's a decurrence thyroiditis. Otherwise, bacterial thyroiditis, thyroid abscess is not at all common. Why I answer, you are written there, no local rise or temperature or non-tender, right? However, with the thyroid, you don't get a tenderness. Is it clear? You don't get tenderness. And local rise or temperature may be seen only in a very vascular tumor. At this juncture, you need to tell the examiners that you go behind the patient, and I have started palpating. Is it clear?
Yes, sir.
Somebody has asked that anaplastic carcinoma thyroid, can it give rise to pain? Yes, whenever there's a very hard tumor infiltrating paravertebral space there, vertebral fascia, growth itself is very rapid and sudden rapid. So it can produce some kind of a dull aching pain. So I just wanted to tell you, pain is feature of anaplastic carcinoma and also lymphoma of the thyroid. I don't want you people to get into trouble in the exam. Keep that pain separate. If they ask you, just say decurrence thyroiditis is the most common cause of pain in the thyroid. Is it clear? Okay. Yeah. So now you need to tell, sir, I have gone behind the patient and I have gently flexed the neck. Gently flex the neck too, so that you are relaxing these muscles also, strap muscles or even sternomastoid fascia, and start palpating with your two hands. You don't say I will palpate with one hand. Both hands, just like a rolling movements of your hand. Both hands, you start palpating. On inspection, swelling is moving up with the deglutition. You have big swelling in front. So you already made up a diagnosis. It is thyroid now. It is thyroid. So you don't have to have any hesitation now. Sir, I went behind the patient. I started palpating. And what is that you are palpating? Srinivasan sir, I asked in the initial stage, thyroid has got two lobes and isthmus. So I need to examine both lobes and isthmus. So you start palpating and then you say what is palpable. That is what I have not made out in this your slides. So I can make out that from your figure. I will say both left and right lobes are palpable. That is number one. Is it correct?
Yes, sir.
Left and right lobes are palpable. See, you're not mentioned there, number one. Number two, isthmus is also palpable. How do you know isthmus is palpable? Yes, simple. If you run your finger beneath your thyroid Adam's apple, all of you can feel your tracheal cartilages.
Yes, sir.
Correct? If any one of you say, sir, my tracheal cartilage not felt, means you have got isthmus enlargement. Simple. Very simple.
Yes, sir.
So you are going to say left lobe is palpable, right lobe is palpable, isthmus is palpable. However, left lobe seems to be much bigger. You have to have a measuring tape. That's what I can understand now, 15 centimeter or whatever. And then you are going to describe surface. See, you are written here, swelling extends under the sternomastoid muscle and next you have jumped to carotid pulse. Without giving any details about surface, borders, consistency, that which you have put in the next slide should come here. Here. Yes. Carotid pulse should come later.
Yes, sir.
You know the schematic presentation of any swelling. Those 10 points are there, which you should not miss. That local rise of temperature, tenderness you have mentioned. Measuring tape, see, variable cystic will come later. Size, shape, surface, borders, skin over the swelling, consistency, mobility, fixity, plane of the swelling, surrounding area, or any other features. Like
Yes.
thyroclossal cyst means you will tell movement on protrusion of the tongue in addition to movement is swelling. So please correct this case sheet. Okay?
Yes, sir.
So no localized temperature, non-tender, then measurements. So can you present this again now, this in a correct way?
Yes, sir. No local, so no local rise of temperature, non-tender. The size is 15 into 10 into 8 centimeters, extending from the upper border of thyroid cartilage superiorly to sternal notch inferiorly. Lateral extent not made out as swelling extends under the sternocleidomastoid. The surface is nodular. Um, the surface is nodular. The borders are well made out. The skin above the swelling is normal. Um, uh, the consistency is variable, firm on most areas, cystic in a few areas.
So I will stop you for two things here. One, swelling is firm, accepted. How did you make out that one area is cystic?
So it was not firm throughout. A few areas felt cystic.
I agree with you. Madam, this is a scientific way of proof that it has to contain fluid whenever you have a small swelling by doing a Paget's test.
Yes.
So examiner may ask you, what is Paget's test? What is Paget's test?
In order to elicit fluctuation in a small swelling, we do Paget's test. Since it's small, we can't use more fingers, so we just use one, press it in the center, and see expansion with the other.
No expansion.
Sorry, not expansion. So I meant since there's fluid, the fluctuation test.
No, don't get into trouble. If a cystic swelling will feel soft in the center, firm at the periphery.
Yes.
It happens when there is a tumor necrosis, tumor necrosis, cystic degeneration. That's what happens. Such a large goiter. You know those pathophysiology of multinodular goiter, stimulation of few areas, which become ultimately necrosis, necrose lobules together, which forms a nodule, and in between the nodules, thyroid tissue may be normal also. Is it clear?
Yes.
So I need to mention that if the examiner asks you, how did you make out cystic? Your answer should be, sir, I have done Paget's test.
Yes.
Again, you're not mentioned to me which side is lobe is big, left or right. That has to be made clear. And also, isthmus. These are the details expected from you. When you have a nodule which is much bigger, say beyond 2.5 centimeter like that, you can use the word bossulated. One look will tell you surface. Such a big swelling is called as a bossulated surface. Borders are thin, consistency is firm. Few areas show cystic, few areas are showing cystic, and the consistency is over. Once that is done, any swelling which moves up with the deglutition, you don't have to mention chin test, all that neck flexion test, etc. Because any swelling which moves with the deglutition, it means it is deep to
Deep cervical fascia.
no. Deep to improve your answer. Deep to pretracheal fascia.
Yes, sir. Deep to pretracheal.
You know, the deep cervical fascia also is a part of that. Yes. So that's how it is. Trachea is in the center. Is it normal in your patient, this finding? Is it, do you expect it to be get shifted? If it is, which side?
So since the left lobe is larger, it could be shifted a little bit to the right.
How did you examine the trachea?
So the trial sign, so the side which the trachea is shifted, the clavicular head of sternocleidomastoid is more prominent on that side. We can also palpate and check, and another way to know is by auscultation.
So ideally, palpate the prominent part of the thyroid cartilage, come down, a case like this where isthmus is grossly enlarged, you cannot do the test. So either a mention trail sign or auscultatory method. Okay. Yes. Next. Actually, now carotid should come. Trachea, carotid, lymph node should come. So don't mention carotid here in this slide. Okay. Everything about the swelling should finish. Only after that. That's why it's called a loco-regional examination. It's not called a loco-regional. Thyroid, trachea, carotid, lymph nodes, in that order, right? Yes. Where did you feel the carotid?
So it's felt against the transverse process of the sixth cervical vertebra, and
so correct. In a large swelling like this, do you think you can feel that in that area, C6 area?
No, so in a large swelling, it is shifted a bit, pushed a bit laterally.
So benign swellings tend to push it, right? Beyond. C6 is also the area of the pharynx becoming dash. MCQ question. What?
The pharynx continues as the esophagus.
Very good. Pharynx becomes the esophagus at that level. Okay. So C6. So ideally, what happens at the upper border of thyroid cartilage? Yes. This is a common question.
The common carotid artery splits into the external and internal carotid artery.
Don't say split. You know, anatomical word have to be not splitting.
Yes, sir. It branches into the
bifurcation. It's called a fork. You know what is fork?
Yes, sir.
Fork of the common carotid. You know, fork of the common carotid. The auriculotemporal nerve goes through that. You know, fork. It's called a fork. All right. So you need to examine for the carotid. I think we'll proceed.
You didn't mention about the lymph nodes.
Because I was not able to palpate the lymph nodes.
No, lymph nodes were able to be palpated. What is the importance of palpating the lower border?
So if the lower border is not palpable, then we should think that it might. I mean, we should suspect that there's a retrosternal extension of the goiter.
Yes. What are the types of retrosternal goiter? You know.
So it could be extending from the thyroid and going downwards, or it could be a plunging type, which is the entire goiter is present in the retrosternal area, and on increasing pressure, like on coughing, it comes back up, or it could be intrathoracic itself.
Neha, you're answering well, but you can answer very brief to the examiners. Substernal, plunging, intrathoracic.
Yes.
It is enough. If they ask you what is plunging, what is substernal, you explain.
Okay.
Please always be brief with the examiners. Okay. Yes. Because we are trying to ask more questions if you answer more. And 25 students per day, the examiners are really tired.
Yes,
and you are trying to answer, you make the examiner more sleepy.
Yes, sir.
So you can, if you say like this, the examiners will be happy.
Yes, sir.
External, plunging, intrathoracic. That is really better. Okay, yes, right.
Next slide. Yeah, that bruit.
Yeah. Yes.
Why you want to auscultate the bruit? This is a common question. Yes.
That is the superior port.
So when there's increased vascularity, like in thyrotoxicosis or in certain malignancies, we can hear a bruit in the superior pole.
Why not inferior pole?
So the superior thyroid artery is more superficial, and it doesn't branch out unlike the inferior thyroid artery. So it's better heard in the superior pole.
No. Superior thyroid artery also gives the anterior and posterior branches close to the upper pole. Okay. Maybe the pressure is more in the axial carotid artery, right? This is a subclavian artery giving rise to thyrocervical trunk, and thyrocervical trunk gives rise to these three. Most of the blood supply comes from the superior thyroid. Okay. So inferior thyroid arteries not only supply thyroid, it is also important to supply for one important organ. Which
The
organ? Parathyroid.
parathyroid.
Correct. Yes, next. I think we will not waste our time at this juncture. Respiratory, CVS, abdomen, all that you need to examine like any other completion. If your case is a primary thyrotoxicosis, they ask you muscular, you are written there, musculoskeletal. So primary, what thyrotoxicosis? Just P for P. Pretibial myxedema you need to know, and proximal myopathy.
Yes.
Proximal myopathy, right? And you also should remember PACI. PACI means thyroid acropathy, another P, PACI. Yes. Thyroid acropathy. All this is in primary thyrotoxicosis. Yes, go ahead. Next.
So the summary.
You need not read all this thing. What is your final diagnosis? We will read it.
The diagnosis: multinodular goiter in euthyroid state.
Multinodular goiter in euthyroid state. Yes. Now, what do you want to? What is your plan of management first?
Sir, one minute. At this juncture, whenever you give a diagnosis, they will ask you two things. Your diagnosis is perfect here. Multinodular goiter, euthyroid state. You can also write non-malignant. I'm only talking about the clinical angle.
Yeah.
Anatomically, why do you say it is thyroid gland? This is the question.
Firstly, the location of the swelling. Secondly, yes, because it's moving with deglutition.
Very good. Third,
so
it's deep to the pretracheal fascia. Yes. Next. What are the parts? It has also the parts, lobes. You got the left lobe, right lobe, isthmus, all that move with the deglutition together. Examiners want to know why not they are lymph nodes or any other for that matter. So anatomically, you think it is thyroid swelling. Why did you tell pathologically multinodular goiter?
So there were on palpation many nodules were present. So based on that,
the answer should be both lobes are enlarged, isthmus is enlarged, and multiple nodules are present, scattered all over. So you say multinodular goiter in your patient, non-malignant multinodular goiter. So one common
thyroid has got three diagnoses, three things you should bring. One is anatomical. Anatomical means is it diffuse or nodular? If it is nodular, is it solitary or multinodular? Okay, now physiological, is it hypo or euthyroid? No, pathological, benign or malignant. That's all. Okay, is it neoplastic or inflammatory? If it is neoplastic, it's benign. So you bring the anatomical, the physiological, and the pathological. So now you tell me the diagnosis as sir wanted to know. Non-toxic, non-malignant, multinodular goiter.
So a common question which is asked at this juncture is, in your patient, if what symptoms or signs, if they were present, you would have suspected malignancy. Just answer to the question.
Sir, if there was a sudden if she had a sudden
rapid.
Sorry, sir. If she had a rapid increase in size of swelling.
Number two. Yes.
Sir, if there was if there was hoarseness of voice or compression symptoms.
Don't say compression symptom. No. Don't say compression symptom. Compression. No. Hoarseness. Enough.
If there was hoarseness of voice.
Please remember, compression will not tell it is malignant.
Yes.
It is infiltration, that RLN. So in the history wise, a rapid increase and hoarseness of the voice.
Yes.
Don't say loss of weight, loss of appetite. They do not occur in thyroid malignancies. Very, very late, very, very advanced. And clinically, history wise, 2 points. Then palpation wise, what are the findings? If present, it is suspect it will be carcinoma or malignancy.
So if it was hard swelling.
Correct. Yes.
If we could palpate lymph nodes.
Hard, irregularity and fixity.
Yes,
you can't even move. Even movement with the deglutition is also affected. restricted. You can't even move. Anaplastic, as I mentioned to you, fixed to the trachea. When the tumor is fixed, infiltrating to the prevertebral fascia, it won't move. Yes, 10 lymph nodes and no other bony swellings. Is it clear?
Yes, sir.
Yes. So now, what investigations you would like to ask?
So, to confirm the diagnosis, I would like to do thyroid function test, USG, and if needed, then USG guided FNAC, and then X-ray neck AP lateral view. Along with that, some routine investigations like hemoglobin.
Just hold on. That is fine. Yes, whenever investigation is asked, yes, your aim is definitely to confirm the diagnosis, no doubt about it. And in case of a thyroid, yes, physiologically functions you need to know. And if there is a malignancy is there, you need to do a metastatic workup and general fitness. I just want you can't say wrong if you say CPP, all that is fine. But urine albumin, sugar and all is nowadays it is not done. You understand?
Yes.
Do a blood urea, sugar grouping, ECG, flexible laryngoscope. Why you want to do flexible laryngoscope?
So for medical legal purposes, because since we're going to operate her and a very small portion of the population, like 2 to 3%, have recurrent laryngeal nerve
don't say recurrent laryngeal nerve.
Unilateral vocal cord.
Vocal cord paralysis due to some exanthematous fever might have happened during childhood. Yes. Maybe your generation has not seen, you have not been affected. When we were small, there are so many exanthematous fever, rampant diphtheria, laryngitis, so many causes of the different exanthemas. So they would have caused some kind of a changes. So one vocal cord paralyzed, so the reason why it is done. But yes, video laryngoscopy are flexible. Yes. What answer expected from you today after that blood test and T3, T4, TSH is imaging. And why do you want to do ultrasound guided FN? It's a good answer. Why do you want to do FNAC? And which nodule you would like to do FNAC?
So since this is a large swelling with variable consistency of both firm and cystic, we would need USG to make sure we're taking the sample from a solid swelling and not the cyst.
Very good. So you should always remember solid swelling. You need to do a fine needle aspiration cytology. Okay. So at this juncture, they may ask you TRARS criteria. It's for postgraduates, just like a BIRATS. You know what is BIRATS means?
Yes, breast imaging reporting data system, like that we have for thyroid and prostate and a few other.
Yeah, so that's fine. So if you know it well and good, otherwise we'll not ask theory now. So what your answer expected is, why do you want to do the thyroid? Number one, it will tell you more or less anatomical area. Like for example, this is thyroid. There's no doubt about in this patient. Second is, we are not interested to know 5 nodules are there, 6 or 8 or 10, but solid area, hypervascular area. There may be 8-10 nodules. One of the nodules is more vascular. One of the nodules is a bit irregular. One of the nodules may have microcalcification. Is it clear? Hypervascular, solid nodule, irregular nodule. And you can also use a ultrasound Doppler to know the vascularity also. That area need to undergo FNAC. Is it clear? So
yes,
depends upon the FNAC. It may be malignancy, it may be benign or whatever it is. Again, do you know any criteria here? FNAC criteria, any criteria you heard of? Bethesda criteria?
Bethesda. So that I think Thai 1 to Thai 5.
Yeah, you read that. You read that. We don't want to go into the theory. So, you know Bethesda criteria, ma?
So I don't remember it. So
no, okay, you will study it. Now, my question, one question is there any role of any Trucan biopsy in thyroid malignancy?
Important question. Important.
Actually, because of the risk of hemorrhage, it's not done. But I think so in lymphoma, it is done.
Lymphoma, and where you don't operate, you can do if it is okay.
The
Very good answer.
anaplastic carcinoma thyroid usually, inoperable or sorry to say hopeless cases, most of it. You need to have some histology before you brand somebody having a malignancy. Anaplastic carcinoma, yes. And also, already Srinivasan sir has given you lymphoma of the thyroid if you have any slightest suspicion. Understand?
Yes.
Then
Yes.
only, otherwise don't mention true cut biopsy. Understand? So we'll come to your case now.
Yeah, I'll give you the diagnosis. Your TFT is normal. Ultrasound shows multinodular goiter. Your FNAC shows schizocolloid goiter. The ECG, everything is fine. Tracheal narrowing is not there. Vocal cords are fine. What is your plan of management? Is it medical or surgical? If it is surgical, why do you want to do surgical management?
So surgical management, because the swelling is very big and there's a chance that it can become toxic. And there's also a small risk that it can have follicular carcinoma in the future.
Yes.
So go for surgical management.
Cosmetic compression or complication and carcinoma. Remember 3 C's.
Even if this patient has no, say, let us say she's not worried about cosmetic because she's married and all, 60. Even if there is no complication according to nothing, but she has come to you, there are very high chances of such a large, big nodules, 4 centimeter, etc. What you mentioned, definitely more than 20 to 30% chance of malignancy may come after FNAC. You understand?
Yes, sir.
It may come to you as a surprise. So it may turn out to be FNAC. Does it tell you follicular carcinoma?
No, sir, because we can't see the capsular invasion, so we can't differentiate adenoma and follicular carcinoma.
So FNAC may suggest could be a follicular adenoma, but it can tell papillary carcinoma. Correct?
Yes.
So such a large nodule. Before you proceed, in this list, I want you to put a CT scan. Is it clear?
Yes, sir.
For patient, especially in this patient, because I forgot to mention ultrasound. One more advantage in this patient, especially is look for the lymph nodes, especially level 2, 3, 4. See, 5 you can make out in the posterior triangle, 5. And you can't make out behind the sternum, that you need a CT scan, but at least 2, 3, 4. 2, 3, 4 is the jugular trunk. They're originally called a jugulodiastich and jugulo-omoid, but better to say now 2, 3, 4 lymph nodes. So that's the advantage with the ultrasound. CT scan is done because any reason?
So there's better resolution. We can see the lymph nodes better, and we can see if there's any retrosternal
that you have seen here. More importantly, various neck is a very small area relatively with so many structures. You would like to know how much thyroid has gone behind, how much it is infiltrate, how much it has pushed the carotid artery, jugular vein, recurrent laryngeal nerve, and even vagus, carotid sheath. So, because you are going to do the surgery for this patient, such a big goiter. So, better to know where exactly these vital structures are present. This information can be made out by CT scan, right? Okay, so if this is a, let us say, non-toxic multinodular goiter, what is the plan? You have prepared her well. This is the picture. So what is the treatment?
Surgical management, total thyroidectomy.
So I think there is no controversy today. Most of the time, your answer, what you should tell is total thyroidectomy, which means, can you tell it completely, which means?
So sorry, so the last one, it just got blocked. Some notification came up. Can you repeat that, sir?
No. What do you mean by total thyroidectomy?
So the entire gland is removed. We don't leave behind any portion, like subtotal thyroidectomy. A little.
Again, I told you, Neha, again you are answering to. You can very well say removing both the lobes,
and this.
entire lobes with the isthmus is total thyroidectomy, sir.
Yes.
So
Sir.
why do you want to go in for subtotal and other thing? Then they will start asking what is subtotal, where do you keep, why do you keep that, and what is Daniel's procedure. All this you can say removing both the lobes along with isthmus is total thyroidectomy.
Yes.
Okay.
So another reason what I have told you, elderly lady, 60-year lady, you have all the reason, more chances of she having a malignancy is in this patient, which may come as histological. So that is why you call it as histological surprise. Is it clear?
Yes, sir.
So you do a subtotal and the report comes as, say, papillary carcinoma thyroid. What will you do then?
So then we'll have to do a completion thyroidectomy.
So second surgery.
Yes, sir.
If you do a subtotal, it comes as follicular carcinoma thyroid. What will you do? Again completion thyroidectomy. So, and such a large goiter, and it is very easy to manage hypothyroidism by giving this patient
thyroxine supplements.
Small dose of thyroxine supplement. But what are the dangers of total thyroidectomy? That you should know. Tell me.
So there is a risk of damage to the recurrent laryngeal nerve, and there is risk of damage to the parathyroid glands.
So these are the two important major problems of total thyroidectomy. So preferably it should be done in the expert center. I think from postgraduates, this much should be the enough. By doing a total thyroidectomy, the fear of malignancy, if it is report comes, is not there. Number one. Number two, recurrence coming back, say after 10 years or so, it is also not there. But also remember the danger involved. Hypothyroidism is not a problem to manage, but hypocalcemia.
Yes.
Hypocalcemia is more troublesome. Of course, then recurrent laryngeal nerve issues are there. So I think that requires a separate thing, discuss about the complications, etc. Sir, at this juncture, I will stop for some time. If they have any questions, they can ask one or two or three. After that, I will take 5 minutes. I have some few important slides. I will show them. That's all.
Please. Any questions on Neha, you have any questions to be asked to us?
No, sir. I think there are some questions in the chat box, sir.
If you can ask me, I'll try.
Potassium iodide, he asked. I said no, not given usually in euthyroid. Okay. It was one question.
There's a question about hemorrhage, sir.
Hemorrhage is there in all cases. You do it meticulously, know the anatomy well, you properly cauterize, hemorrhage is not at all a problem. In the recent instruments which we have, and myself and professor studied, I think so, we were using catgut to tie small bleeding. Now cautery has come, you have the dipolar, monopolar, bipolar, you have vessel sealer. So you have a perfect hemostasis. So the hemorrhage is not at all a problem. Okay, Neha?
Yes, sir.
Sir wanted to share some slides or something.
I'll just, please allow me to share.
Priya, can I ask? Meg?
Yes, I can share.
I'll just check.
Yeah.
Just give me 1 minute time.
What is that? Okay, before sir starts, we'll ask you a question. What is the incision which you put, ma?
So there are two types of incisions that can be used. One is the Weil's and the other one is the Kocher's incision.
What is Weil's?
So it's 2 centimeters above the sternal notch and around 6 to 8 centimeters horizontally. Yes, sir.
This one, there's only one. Okay.
Can you see, sir?
Yes, sir. Beautifully said. You can make it. Yes, sir.
Yeah, see,
Oh my.
this is actually a patient from Sulia, that Virajpet, that area. This is
Oh my God.
classically you can mention as, bossulated surface, like a elephant. But in spite of that, remember, she never have any symptoms, sir, interestingly. No compression, no dysphagia, no recurrent linear, and you can see it's almost hanging in front. So anyway, that's about that story. This is how the present slight extension of the neck will make the thyroid more prominent, right? This is a classical case. You can see the lower eyelid and all thyrotoxicosis. This is Pigelos method. I think all of you know, the clasp the hand behind the occiput there. And what is this sign called as?
The
Hands touching
Pemberton
the
sign.
ear. Yes.
Pemberton sign.
You can see now the veins there. Can you see?
Yes, sir.
That your hand should touch the ear. Okay.
Yes.
Examination should be done from behind. Watch both hands carefully. You are nicely presented. In your patient, the Kreitz method and Lahe both may not have any significance. Suppose you have one nodule felt, one nodule. You have a doubt, because if it is one nodule, it is solitary nodule. If you have one more nodule you feel in the other side, your diagnosis changes to multinodular goiter. Simple. So, Kreitz method, you use the thumb. You just press with the thumb, ask the patient to swallow. When the gland moves up and down, the nodularity becomes better. This may not have a great significance today because you have the ultrasound which can pick up a nodule. The examiner asks you, you should know. You understand? Till you are a student and till you finish your MBBS or MS, maybe few more years, it may change the teaching. Carefully watch the second. How do you do the Lahe method? Remember, this lady had a left lobe enlarged. Look at my right hand, it's feeling that posterolateral surface. But see the left hand. This is left finger. It is touching between the trachea is here. Between the trachea and the lobe. Is it clear? Between the trachea and the left lobe, you put your finger and push. I hope it's clear. You want to check on the left side, the nodule. This is the left lobe. This is my finger. It is between, this is the lobe and trachea is on this side. That is, you push like that and feel from the right hand, the other side. That is this is Kocher's test or a Cocker's test. I didn't see that test in your presentation, which probably examiner will expect because this is a long-standing goiter of 10 years duration. She may not have any symptom of difficulty in breathing. Don't wait for that. Gentle compression. If patient becomes a bit of breathless, you need to keep this information to the anesthetist, and you also should know, so that when you are removing the thyroid, you feel gently the trachea. If it is very soft, sometimes anesthetist will keep the tube overnight. And there are some methods how it should be managed, but I just want you to understand why Cocker's or Kocher's test is done. So Theodore Cocker is the first man who got the Nobel Prize in surgery. You know, there is a Cocker's incision, Cocker's forceps, Cocker's vein, Cocker's subcostal incision, Cocker's test. Then there's one Cocker's method also, I think, for dislocation or something for the upper limb. Just to know about the Cocker. Feeling the trachea in the center is a thyroid prominent nodule. Sorry, trachea here. Just gently, you're feeling in the center. Now look at that nodule on the left side. See this figure very clear. How the trachea has been shifted. And look at the sternomastoid. See that? So very nice case to demonstrate the pressure effects. How it can move. See the nodule. See the sternomastoid and see the trachea. So that's how it is. So upper border of the thyroid cartilage, that's the tracheal bifurcation, not a splitting of the trachea. Okay, yes. Not splitting of the trachea. And of course, Berry's sign, in which there's a big thyroid carotid has been pushed in the posterior triangle. What is the spot diagnosis of this lady? Spot diagnosis, Neha?
Probably so it's follicular carcinoma, and that has a metastasis to the skull bone, and that's a swelling.
Thyroid and veins are prominent there, and you look at that metastasis ulcerated, little blackish spot. Can you see that? I'm not sure whether you can see on the summit of the ulcer swelling. Of course, this is a case of, see, I have marked, I am the surgeon. On table, I mark something. What is that? What is that?
Lymph nodes.
Yeah, this is actually a papillary carcinoma of the thyroid patient having 2 nodules here. And that's the incision marked. And that's a 2, 3, 4. Patient had these nodes. It just for the sake of demonstration only has been marked. Yes, if Neha can give a diagnosis, we will give her one special prize in the White Army. I will talk to Krishna Rao. Yes, tell me.
So is this like tremors in the tongue because of hyperthyroidism?
No.
Okay.
No.
He has shown you a photo, not a video.
Try.
Can I ask you one thing? What are the things you see in the oral cavity with regards to thyroid?
Then you may get a
you said thyroid fasciculation, thyroid tremors is it. Now, the third one is query. You tell me.
Sir, we will give her a clue.
Yeah, what is this one?
There is a thyroid swelling.
The lingual thyroid.
Just don't be in a hurry. Lingual thyroid is in the tongue or in the, this is a thyroid swelling in the neck.
Yes, sir.
And look at his tongue and look at the lip. Look at the lip. Mucocutaneous.
Mucosal. Oral mucosal.
Which condition you get thyroid swelling and mucocutaneous neuroma? You have already mentioned in the presentation sometimes. Medullary.
Somebody is in the chat box also.
Medullary carcinoma of thyroid.
You mentioned somewhere men 1,
men 2A and men 2B.
What is men 2A?
Men 2A is.
Yes. What is Sippel syndrome? Sippel.
There's parathyroid gland, parathyroid, and then pheochromocytoma and medullary carcinoma of thyroid.
So please, anyway, this is a lady who had undergone a thyroidectomy 1 year back, and she comes with a small nodule, nodule-like thing here, short case, here. So this was papillary carcinoma of the thyroid, and this was a big lymph node. So commonly they ask here, and here, 2 lymph nodes. Pretracheal node, it's also called a Delphic node, pretracheal. And this is actually somewhere between 2 and 3 is a level 3 node. So this was papillary carcinoma thyroid. Okay, right. So these are my presentation, and from my side, I will unshare now, and we'll take 1 or 2 questions if you want. Somebody has
wonderful pictures, sir. You got it.
Thank you, sir.
Pictures will give some information.
No, these pictures you put it in your mind. Never forget.
Because advantage of the surgery, even online, I was telling that images. See, surgery, clinical pictures, palpation is one restriction. Otherwise, inspection findings can be explained with many times the pictures, whether it's a carcinoma, stomach, thyroid, breast, any for that matter.
After a few years, you see a patient with thyroid with oral neuromas, you will remember it. Yes. You should remember that is brain.
Okay, well done, Neha, for your final year. And when are you giving exams?
Next. Hopefully by next year.
Yeah, hopefully by January.
Only Rajiv Gandhi and the MGR University have completed. MGR University results came yesterday. Rajiv Gandhi results came Kerala, they postponed to 15, 17, 26 now. It's keeping on postponing, sir.
I think her batch is supposed to give exam next year, I think.
So I just finished my 3rd year and we just started 4th year this month.
Yeah, she's giving exam next year. Only thing is they will miss the clinical post. Okay, thank you everyone. Neha, you